Okay, what is everybody having trouble with? Have you guys read the content? I'm trying to share my application with you. Can you all see my screen?
Yes.
You can? Okay, hang on one second. Okay, good. Okay. All right. So I can't see you right now because I am in my OneNote, okay? So if you need me, you're going to have to say something because I won't see you like raise your hand or anything. All right, so I'm going to just briefly go over connective tissue diseases, which are also autoimmune disorders. Okay, so basically with connective tissue disorders, they all have many of the same signs and symptoms, but usually there's some distinctive characteristic within the disorder that you're like, oh yeah, that's not lupus, that's rheumatoid arthritis because they have a swan neck deformity of their hand. Okay, so I'm going to start with rheumatoid arthritis. And this is what I was just talking about, this swan neck deformity. Okay. Now, rheumatoid arthritis is a type of arthritis that results in early morning stiffness, and they have red, swollen joints, and it's symmetrical, meaning it's on both sides of the body. Okay. They also may have a low grade fever when they're having exacerbation. So all these connective tissue diseases, they have periods of remission and exacerbation, okay? With rheumatoid arthritis, like many of the connective tissue disorders, they can have other complications such as pericarditis and pleuritis, which I will talk about when we get to the cardiac and lung lectures, okay? Now, they can get this condition called Raynaud's phenomenon, and I'm going to go over that in a little bit because that's tested in ATI a lot. The diagnostic studies, now these studies right here, the high WBC, that's due to inflammation, C-reactive protein, this is a inflammatory marker. So it's non-specific to rheumatoid arthritis, but you will see it elevated when there is inflammation in the body, okay? They will also have an elevated inflammation rate, same thing. It's an inflammatory marker, and you'll see it in a lot of conditions that cause inflammation. The ANA antibody titer and rheumatoid factor. Okay, so people with other inflammatory diseases can also have an increase in rheumatoid factor. So it's not specific to rheumatoid arthritis. And then with your nursing care, okay, so when they wake up in the morning, they cannot get moving right away. They have a lot of stiffness in the morning, and heat can really help, like paraffin wax for the hands, or like if they're going to have a hot cup of tea or coffee, they can put their hands around it. A warm bath is good before they get up and exercise. That could like help warm up the joints. And with all patients that have a disease that can cause immobility, we always want to promote independence and keep them moving for as long as we can. Okay, so obviously with rheumatoid arthritis, now this can affect the small joints of the hands and the feet. So if it affects the feet, even with the hands, they may not be able to grip onto side rails and etc. So make sure the environment's safe for them. Okay. We always want to encourage the use of assistive devices to keep them independent. Now, people with rheumatoid arthritis should exercise daily as tolerated. And that means they shouldn't exercise if they're having a flare up, or they shouldn't exercise past the point of pain, right? So you never want the joints to feel pain when they're exercising. And if they don't say today, I don't feel good, so I don't exercise, I shouldn't do double tomorrow. You just pick up where you left off. They should take anybody with a connective tissue disorder or when we get to HIV, they need to take their temperatures daily, okay? Because you want to make sure they don't have an infection because they're going to be prone to infections. You're going to teach them how to conserve energy. Now, we talked about that in the anemia lecture. They're going to have to alternate periods of rest with activity, and they need to engage in medication compliance. Now, I put the meds on here. I don't know if you've had them in pharmacology. Usually I just put the meds on here with a mnemonic or something in case you'd like to use it, okay? Now, let's talk about lupus. You're going to definitely have to know the signs and symptoms of lupus. Okay, they are going to have a malar rash. That means a rash across the cheeks. The discoid rash is a skin rash. So there are two varieties of lupus. I should start there. There's the systemic version, which is what we usually talk about in nursing school. And then there's the discoid version of it where they just have a rash on their skin. They can have serositis, so that means inflammation of the serous membranes. So inflammation around the heart and lungs and the peritoneum, which is so around the abdominal cavity. Oral ulcers and arthritis, anemia, and alopecia. Photosensitivity. So with lupus, they really have to try to stay out of the sun because that could exacerbate their lupus symptoms, okay? And they can have pancytopenia because the spleen becomes inflamed. And so you remember that causes anemia, neutropenia, and thrombocytopenia. So you know the interventions for that. They can also become depressed, confused, and apathetic. All right, and then they have the Raynaud's, they have the pericarditis I talked about earlier. So those are the complications. Now, you want to monitor for pain and make sure you medicate the patient, and then evaluate when you medicated the patient. Encourage periods of rest with activity because they're probably anemic and they're going to be tired anyway from having an autoimmune condition. Monitor for renal failure. I'm going to teach you that next semester. So look for the high BUN and creatinine and low urine output with edema. All right, so you need to teach the importance of med compliance with any autoimmune disease because they're going to be on many meds, okay? And many of them are immunosuppressants, so you have to teach them the importance of med compliance. They need to take their temp daily as well. Minimize sun exposure. They need to wear, a big hat when they're out in the sun, long sleeves and pants. The SPF of sunscreen has to be 30. Okay, so that's important too. I got burned on an ATI question with that. They need to report any flu-like symptoms, flushing, and they should apply lotion to their skin, BID, because their skin can get thin. And stay away from crowds. Anybody with an autoimmune disorder should stay away from crowds. All right, Raynaud's. Raynaud's phenomenon is arterial vasospasm in the hands, and usually it's one-sided, but it can be both sides. And what happens is they have an arterial spasm in their hands when they're exposed to cold weather. And the hand will turn different colors. First it will turn white, then it will turn blue, then it will turn red. It's because the arterioles in the hand are spasming, okay? So the patient needs to wear a lot of clothes outside. They need to stay warm. If they're going to grab something out of the freezer, they may need to put gloves on because that could trigger it. They shouldn't smoke because smoking causes vasoconstriction. And then they need to manage stress. That's another thing. And they should exercise to promote their circulation. Okay, gout. Gout usually affects one joint and it's due to a high level of uric acid. So for some reason, they get their body produces uric acid, and maybe they can't excrete it from the kidneys. Okay, so what you need to know is, of course, they're going to have the elevated ESR, but this is what's important: the diet. No organ meats or shellfish. So organ meats are liver, kidneys, and heart. They need to stay away from that because it elevates purines in the diet, which somehow turn into uric acid. They need to limit alcohol, stress, and increase fluids to flush out the uric acid. All right, now I'm going to go in. Does anybody have any questions on that?
No.
Okay. I'm going to talk about anaphylactic reaction or shock. So usually this is because they've been triggered by something they're allergic to, and it causes the release of histamine into the body, okay? So histamine is going to dilate all the small blood vessels. That's why they can get like flushing and also fluid leakage into the tissue. They can end up with circulatory collapse, shock, and die. So we have to recognize it early, right? So they develop hives, angioedema, which means swelling underneath the skin, wheals, which is like kind of like a big mosquito bite, tachycardia with decreased amplitude. So the amplitude of the pulse is a normal pulse is +2. So the amplitude may be lowered because of all the vasodilation that's going on. They're going to have a low blood pressure, but we worry about bronchoconstriction, wheezing, and itchy skin. We don't really worry about itchy skin, but I mean, it could tip us off that something's going on, but we really worry about these vital signs and the bronchospasm and wheezing because that can lead to death. Okay. All right. So to treat anaphylaxis, first thing that's got to be on your mind is keep that airway patent. All right. So you're going to put oxygen on the patient. You're going to lift the head of the bed if they're not have hypotension. You make sure the IV's patent, okay, because you um, may need to call a code. Antihistamines are given, epinephrine, and mental health support because somebody who is having difficulty breathing is going to be extremely anxious. Never leave the bedside if you have a patient that's extremely anxious. Use your call bell or use the rapid response to have people come to the bedside and help you. Now, this is an important statement I'm going to make. Epinephrine can be given IV, IM, and SC, or by the endotracheal tube, okay? What you really need to know that's really important is only dead people can get IV epinephrine. And what I mean by that is you only give IV epinephrine during a code. So when somebody has had cardiopulmonary arrest, you may give epinephrine SC or IM for a reaction, but not IV. Okay, a reaction means they're having these symptoms and they're still alive, right? You still have a heartbeat, you still have a pulse, you still have a blood pressure. IV epinephrine is given when they're in cardiac arrest, so no pulse, no blood pressure, no vital signs, they're unconscious. Okay, so that's kind of the difference. All right, let's go into HIV. Now, a lot of these informations, lucky for you, are very similar to the neutropenic um, precautions we talked about in the cancer lecture. So typically what happens when somebody's infected, 2 to 4 weeks after the infection, they feel like they have the flu. They get the night sweats, they have a fever, sore throat, rash, okay? Then those symptoms resolve and they end up having lymphadenopathy. So that means swollen lymph glands, okay? In the next 10 years, they could go asymptomatic, all right? And then they could develop AIDS, which means they have opportunistic infections, which I will talk about, but also their CD4 level is going to be less than 200, okay? Now, it's transmitted through infected blood and body fluids, semen, vaginal fluids, amniotic fluid. There's a lot of fluids that HIV is found in the body, right? But these are the ones that it's transmitted through semen, vaginal, and mom to baby, okay? All right, so risk factors, I think you know these. Unprotected sex, healthcare workers are at risk. Hopefully you're practicing safe practices with, putting your needles or your syringes, I should say, in the red bucket quickly. Um, so with complications, there's a number of opportunist infections that they can get, right? They can have tuberculosis, which we're going to talk later in the semester about, okay? They get a fever in the afternoon and night sweats. If you hear those two symptoms together, you should be thinking tuberculosis. They can develop sepsis, especially when their CD4 level is low. They can develop pneumonia as well when their CD4 level is low. They get viral infections, herpes zoster. So that's a chickenpox virus, a varicella virus. So you got to put them on airborne precautions. HIV-related malignancies, Kaposi sarcoma. They get these red or purple lesions on the skin or inside the mouth. Wasting syndrome. So this is like they have like a 10-pound weight loss unexplained, right? They look cachectic. So they suffer from malnutrition. They'll have diarrhea. They can't tolerate fat anymore, and mouth sores and anorexia. So anybody with anorexia, I know you probably had this in fundamentals. When you're trying to encourage them to eat, you don't want to give fluids before or during a meal because it will fill them up. Okay, you want to give them supplements if they'll take them. Do the things where family brings in favorite food if they can. Okay, because if their CD4 level is really low, they may not be able to bring in things from the outside. Okay, but malnutrition from wasting syndrome is going to put them at risk for, not neutropenia. Malnutrition plus neutropenia puts them at risk for sepsis and infection. Okay, so just keep that in mind. All pregnant women need to be screened. They could suffer from pancytopenia. Um, so here are the nursing implications. These are the same as teaching, as neutropenic teaching. So they need to take their temp daily. They need to wash their axilla and genitals 2 times a day with antimicrobial cleanser. They need to bathe daily. No fresh flower or plants. So that should sound familiar. Don't empty the kitty liver. Stay away from sick people. Avoid crowds. Okay. They cannot eat raw or undercooked food. No fresh flowers. Wash dishes in hot water and wash their hands. And maintain medication compliance. All right. All right. So this is what wasting syndrome looks like. You might be able to pull that up better on your worksheets. And Kaposi's sarcoma has the red and purple blotches. Where are my sheets? Oh, they get pulled way down here. Okay, so you should compare fluid overload with fluid deficit. All right, and notice what's the same and what's different. Okay, so with fluid volume overload, that means overhydration. So obviously they have too much fluid in the body. Either they can't remove it, like if they had a kidney disease, or the intake's too much, okay? Like maybe they got too much IV fluid. So that's why you have to be careful. So the complications of too much fluid could kill them. They could get pulmonary edema. It could exacerbate chronic heart failure. Okay, so who's at risk for fluid volume overload? Older adults because they have a reduced kidney function. Anybody taking in excessive fluids like IV, PO, enteral. We're not going to talk about SIADH. I talked about that in the cancer lecture. So what you're going to see in somebody with fluid volume overload is edema or anosocre. Anosocre is all over body edema. The edema may be pitting, and I talked about how to document that or recognize that in another lecture, and you would definitely need to read up on that, okay? They're going to have weight gain. They'll have tachycardia with a bounding pulse. And just think there's a lot of fluid in their vascular system, hopefully, and so they have a bounding pulse. They have tachypnea, that means they're breathing fastly, and hypertension. They could have seizures if their sodium goes low due to the hemodilution. If they have pulmonary edema or they're developing, they may develop a new cough, especially at night, crackles, and dyspnea. Pink frothy sputum means pulmonary edema. Okay, so that's what you're going to see in pulmonary edema. So if somebody does, they'll have to be short of breath, they'll have orthopnea, that means they can't lay flat, okay, in a low O2 sat. All right, so what are we going to do about it? They're going to need diuretics, of course, probably restrict their fluids and sodium. If they have kidney problems, they'll need emergency dialysis if they're doing really poorly. You need to assess daily weights, I's and O's. If somebody does have pulmonary edema, you raise the head of the bed first, then you put on O2. The patient needs to be on bed rest. So when patients have edema, we put them on bed rest if it's significant, because when people lay flattish, the kidneys are better perfused, and that helps them excrete through the urine the fluid. Okay. So like that's why somebody with like right-sided heart failure who has edema, when they lay down at night, they develop nocturia, okay? Because the kidneys are better perfused and the edema is going inside the vascular system, and so they put out more urine. And we'll talk about that more when we get to the cardiac lecture. All right, you want to turn Q2. Anybody with edema is going to be at risk for skin integrity issues. And we always report a weight gain of 2 pounds per day or 3 pounds per week. So you have to teach that to patients. Now let's contrast with fluid volume deficit. Okay, now older adults are at risk for fluid volume deficit because they have a decreased thirst reflex. They don't remember to drink. They have decreased concentration ability of their kidney. So they could be more excreting more urine that's closer to water concentration, okay? Prolonged fever can also lead to fluid volume deficit. Bowel obstruction. You can sequester up to 5 liters of fluid in your bowel if you have a bowel obstruction. So that's pretty significant. Now they're going to have a high H&H, so that's hematocrit and hemoglobin due to hemoconcentration, high specific gravity because they're dehydrated, and high sodium. All right, their neck veins are going to be flat when they're laying flat. Okay, that tells you that they have fluid volume deficit. All right, so they'll have dry mucous membranes. Tachycardia is going to be the earliest sign, but their pulse is going to be thready. Okay, they'll have tachypnea, just like fluid volume deficit. But with fluid volume deficit, the pulse is thready. They'll have hypotension, and it can lead to orthostatic hypotension, so they're going to be fall risk. They could have decreased skin turgor, which is not accurate on older adults, okay? So I would not use skin turgor as an assessment finding in older adults. The cap refill is going to be sluggish, so greater than 3 seconds. They could have attitude changes. What that means is that when they're dehydrated, they can get confused, weak. They'll be thirsty, people will be thirsty, and they'll have weight loss and an elevated temperature, okay? Their urinary output will be low, and they'll have a high specific gravity. All right, falls, make sure you know the nursing interventions for falls. So usually due to orthostatic hypotension. So the bed needs to be low, the call bell in reach, and we need to monitor gait stability. This Romberg test, now if somebody has repeated falls, right, they may have some neurological problems, so the provider will do a Romberg test, and that's a test of balance that you're going to need to know about, okay? So the provider does it, the patient stands up on bare feet, closes their eyes, and put their arms out in front of them. And if they start to sway, then they know there's something going on. All right, so you want to, for your patient, you're worried about hypovolemic shock or acute kidney injury, because the kidneys need to be perfused to work properly. They could get DVTs because when they're dehydrated, there's venous stases, and that can cause DVTs, okay? And so you're going to insert a 20 gauge IV at least, a 20 gauge, bigger if you can. They're going to need IV fluid boluses, okay? And you're going to push PO fluids as tolerated. Monitor the vitals and check for ortho. Assess their mentation. That means their LOC. Like assess how they're doing cognitively. Check for pulse amplitude. +2 or higher is good. Less, so +1 is not good. Encourage them to change their positions in bed so that their skin doesn't break down. Tell them to rise slowly. Monitor their weight doing fluid resuscitation. So when you're giving boluses, we call that fluid resuscitation. So you monitor the weight during it. Monitor the urinary output. Do you guys know the normal urinary output?
Ain't it 30 mLs?
30 mLs per hour, yes. So you want the cap refill to be, so you know they're doing well, know how to evaluate, okay? So if they're a young person, the skin turgor improves, the specific gravity is now in a normal range. All the labs are going back to normal, their skin's warm, the cap refill is now back less than 3 seconds, okay? So that's how you can tell they're doing well. All right, with electrolytes. Okay, sometimes it helps people to know what the electrolyte actually does in the body. I mean, you don't have to get too deep with it, but sodium helps us maintain our BP. It helps us contract our muscles, helps with the balance of body fluid because where sodium goes, water follows, right? And it helps with the transition of nerve impulses. That's why you have all the symptoms you do, okay? So with hyponatremia, they are at risk for coma and seizures and stupor. Okay, so in other words, they're going to have a change in their LOC and they could have start seizing. They're going to be anorexic. They'll have lethargy because they got to have a change in their LOC. All right, they're going to have tachycardia, limp muscles. They'll be weak. Okay, because sodium helps with muscle contraction. They'll be orthostatic and they'll have stomach cramping. A lot of sodium, on the other hand, they're going to have fluid retention. They'll have an increased BP, they'll have pitting edema. Okay, their skin's going to be flushed. So they have a rosy skin, low grade fever, and the tongue is red and swollen. Okay, so you're going to do to the nursing care involves weighing daily, and what you report is the same for everything. You report 2-pound weight gain in 24 hours or 3 pounds in a week, right? They may get IV fluids, and you're going to have to tell them that they can now have salt in their diet so they can eat foods high in salt. So like processed foods, canned foods, ketchup, dried fruit, cheese, and pickles, okay? So those are foods high in sodium. You need to know foods high in sodium. That's sodium. Potassium's a pretty big deal when it comes to the heart, okay? So with potassium, this helps you in muscle contraction of skeletal, smooth, and cardiac muscle. All right, it helps transmit nerve impulses. It helps with acid-base balance. Okay, so if you have a low potassium level, you're going to have hypotension. You could have tachycardia with that. You're going to be lethargic. Okay, you're going to have low, shallow respirations. In between your rib cage, in between your ribs, are intercostal muscles or extracostal muscles. They help you breathe, right? So if they have too little potassium, which helps us contract skeletal muscle, the muscles are going to be weak, so they're going to have low, shallow respirations. They can have lethal cardiodysrhythmias. They can get all kinds, and we'll talk about that a little bit more, but you need to know they could get tachydysrhythmias with low potassium. They're going to have lots of urine. So having a low potassium affects the kidneys, and they develop a condition called diabetes insipidus, which has nothing to do with blood sugar. Okay, so they can put out a lot of urine. They can have leg cramps, limp muscles, low blood pressure. Oh, I did that twice. Less stool. Okay, so it slows down the smooth muscles of the bowel, so they can develop constipation, ileus, and bowel obstruction. Okay, they have a low amplitude of the pulse. That means their pulse is going to be thready, weak, and irregular. Okay, because they could have dysrhythmias. So thready, weak, and irregular pulse. All right. Now their potassium level is going to be low, and you get the so lower than 3.5. But remember, you get the values on the exam. The ABG with a low potassium is alkalosis, metabolic alkalosis. Anybody with either a low potassium or a high potassium needs an EKG as soon as possible. Okay? You want to get them on a telemonitor if you have one available as soon as possible, because just a small change in the potassium level could result in a big change in cardiac function. All right. So you're going to have to give potassium PO or IV drip. We never give it IV push. They must be voiding 30 mLs an hour. Check their respirations. Monitor the cardiac rhythm. You always check a potassium level before giving digitalis, even though we don't give it that much anymore. It is highly toxic if they have a low potassium and you give them dig. It's going to potentiate dig toxicity. Monitor their LOC, check their hand grasp. That's like a quick, great way to do it at the bedside to determine their strength, okay? Monitor vital sounds because they may become hypoactive. Check for deep tendon reflexes, okay, because they may be decreased. And monitor the IV site if you're given IV potassium because it can cause phlebitis. All right, and these are your
I have a
foods.
question.
Yes.
Okay, let me see how I can word it. So, all right, say if a person has pneumonia and they're presenting signs of hypokalemia, will we hold the potassium until we get their O2 stats 95 and above if their O2 stats were low? Or could we still administer the potassium?
No, okay, so having a low potassium can kill them. So that's got to be a priority, both. I mean,
Okay.
they can, why did you put pneumonia with hypokalemia? What made you say that?
I only did that because I was diagnosed last week with both. So I was wondering because I see that like we gotta check the vital signs and all that good stuff. But if they're already having trouble with, you know, those vitals, I didn't know if we wanted to get those vitals back stable before we administer, or if
No,
you
no, no,
the
no. You
administering would
okay? So
change the
you would,
vitals.
yeah, no. You if they have a low sat, you're gonna like sit them up if you can, if their blood pressure is not too low. Because if you when you put somebody upright, that drops the blood pressure further. So it kind of depends on how
Right.
stable they are. But put the
Understand.
oxygen on, you can get the potassium going.
Okay.
Yeah, yeah, yeah. So that wouldn't be a problem. All right. And then hyperkalemia, okay? They are also going to have muscle, I'm over here, murder, okay? Use the mnemonic murder. So they are also going to have muscle weakness. The difference between this muscle weakness and the muscle weakness of hypokalemia is this muscle weakness is ascending, meaning it starts in the lower extremities and works its way up. So when it gets to like the thighs, you might need to start worrying because pretty soon it's going to be at the intercostal muscles and they may need to be intubated. Okay? So just keep that in mind. They're going to have a low urinary output. They could have respiratory failure for what I just described. Okay, they can have decreased cardiac contractility, so that means the weak thready pulse, same as low potassium, weak thready pulse. Okay, they can have diarrhea because the smooth muscle is affected in the bowel and it irritates the bowel. They can have early muscle twitching. Um, and rhythm changes. Like they usually with high potassium, they can like heart block, so and everything slows down and they can go into cardiac arrests, okay? So people with high potassiums, you'll see the ABG will be metabolic acidosis, and they'll have a high potassium level, and anybody, they need to be on a monitor, okay? So you're going to try to prevent falls because of the ascending weakness I talked about, monitor the cardiac rhythm, check the muscle weakness. If they develop a life-threatening dysrhythmia, they will need calcium gluconate. It doesn't lower the potassium, but it helps protect the effects of potassium in the heart, okay? So calcium gluconate is that antidote for the heart. In the medicines, you can use the mnemonic chyme, so they can get caxylate, which helps them excrete it in the feces. Insulin and dextrose help potassium move inside the cell, and you'll go into more depth in MedSurg 2 with that because they give that for people with diabetic ketoacidosis. So foods low in potassium, apples, corn, green beans, that's good to know. Okay, so we're going to focus more on hypocalcemia because I did hypercalcemia for the cancer lecture, okay? Calcium helps strengthen our bones and teeth, helps us with muscle contraction, nerve impulses, blood clotting, and we need vitamin D to absorb calcium. So calcium is kind of like a sedative to the body, okay? So if we do not have calcium in our body, we're going to be irritated, have convulsions. We'll have something called Chvostekstein. We can have circumoral perianesthesias. So that's usually one of the first signs, the numbness and tingling around the mouth, perioral or circumoral. They have arrhythmias, tetany, trousseau-sign. I'm going to show you what those are in a minute. And they could develop laryngeal stridor, which is life-threatening, okay? And low calcium can occur because they have kidney disease or some kind of condition which causes malabsorption. Okay, so trousseau-sign is carpal pedal spasm. So again, they have tetany, right? And it's a reaction to blowing up this blood pressure cuff, and you keep it inflated for 3 to 4 minutes. Like nobody's got time to do that, but this is highly tested, okay? So if the hands and fingers go into a spasm like this, then you know it's low calcemia, low calcium. And this Chvostek is tapping on the facial nerve, right, like right in front of the ear, and then their face will twitch. Okay, so that's Chvostek and trousseau-sign. All right, so the nursing care, we want to they'll be on seizure precautions because they could seize from this, and fall precautions. Keep them calm and quiet because they have tetany, anxiety. Okay, limit visitors. Don't let more than 2 in a room at a time. Encourage foods high in calcium, and check their deep tendon reflexes. Make sure you know the foods that are high in calcium because you're going to encourage it, especially even in the musculoskeletal lecture for osteoporosis. You want to make sure people are eating high calcium foods. So green leafy vegetables are a cheap, cheap way to get calcium if you grow them yourself. Dairy, salmon, sardines, and oranges are pretty good with calcium. All right. Now, magnesium, you don't even have to memorize this because I'm going to show you something. This is the same thing. It's due to malabsorption because all these things can cause malabsorption. And it's a different mnemonic, but the signs and symptoms are all the same. Okay, it's calcium. All right. Now, the nursing care, you may have to give IV magnesium, and when you're giving IV magnesium, you got to check the deep tendon reflexes every hour while you're doing it. Now, because what can happen is, I mentioned before that calcium was like a sedative. Magnesium is the same way, right? So if you're giving magnesium, that could affect the respiratory rate, okay? So they could, have problems breathing, or they could breathe slowly. So your antidote for that is calcium gluconate, Okay, so that's important to know. How are you guys doing on ABGs? Have you
Need
been
more
practicing
help.
more help? Okay.
Yeah, it's just confusing because it's like, I mean, I know each test they'll give us the lab values and then we can distinguish like which one is low, but for me it's more so picking out which I keep confusing the two A's.
Yeah, I'm still confused as well.
You're okay. So you're confusing the what? Say it again. The two what?
The two A's is like the metabolic I can't pronounce the
Acidosis,
words. Yeah, those two words. Like I keep
osmosis.
yeah, those ones. I keep mixing them up.
Okay,
With
all right.
which
Let me
one
just
goes
go
with
kind
which
of go
value.
through. Let me just kind of go through Rome, okay, and see if this helps. Okay. Now
Okay.
the values measured. Okay. There's going to be 5 values on a blood gas. Okay. The pH, the PaCO2, the PaO2, the bicarb, and the O2 sat. Okay. These are the normals which you're going to get on your exam: 7.35 to 7.45. 35 to 45 for the PaCO2. The PaO2 is 80 to 100. Okay, you're going to get that on an exam. So the bicarb is 22 to 26, and the O2 sat is 95 to 100%. If you're asked to identify an ABG, you're going to look at the pH, the PaCO2, and the bicarb. If you're asked if the patient is hypoxemic, you're going to look at the PaO2 and the O2. Okay? All that's to say is the only values I want you to look at when you are going to look at an ABG to identify it is the pH, the PaCO2, and the bicarb. Okay? I want you to take your scratch paper and write pH on it, CO2 on it, and bicarb. Then you're going to write your ABGs that you were giving on your exam. There's no shame in it. I'm going to show you how to do this. Okay? So you're going to write arrows up and down. Is it increased, decreased, or normal values next to the 3 values? Okay? Then you're going to identify the ABG's last name first by the pH. Okay? So if my pH is over 7.45, I put an up arrow. My ABG last name is always going to be alkalosis if I have an up arrow next to the pH. Okay? If I have a down arrow, so if it's less than 7.35, my last name is always going to be acidosis. Okay? You got that? So come down here. All right? So I put this arrow here, that's up, and this arrow down. Okay? So have you heard of the term Rome? Respiratory opposite, metabolic equal? Have you
Yes.
heard that term? Okay. So this pH is what? Is it alkalotic or acidotic?
It's up, so it's acylated.
Alkalos.
So alkalosis, right?
Oh
So your
yeah,
last
alkalosis.
name of this ABG is alkalosis. Okay. If the arrow is going opposite the pH, it's respiratory. If the arrow is going the same as the pH, it's metabolic. Okay. So we said this was alkalosis, and we've got an arrow that is opposite. So what is this condition called?
Respiratory.
Respiratory alkalosis. Very
Okay.
good. Okay. So just write your arrows. So here we go. This is 7.31, so I put a down arrow. This is an up arrow. So what do I have here?
It's it's acidosis.
Acidosis. The arrows are going opposite. So what's the first name?
Is that one? Hold on, wait, P. Is
Is it
that
metabolic?
is it
Rome.
hypoxemia?
Remember, respiratory opposite, metabolic equal. Yes, you said respiratory acidosis, right?
Respiratory. Okay.
Because the last name is acidosis. These arrows are opposite. Okay. So this is like the hardest part to teach. It's easy when we do our activities tomorrow. It'll be easy to like talk more about like what happens in the body, right? This is like the biggest hurdle you have to get over. Okay, so let's do this one. What is my last name of this one?
Acylosis.
Okay, alkalosis. And these arrows are going the same way. So is this, what's the first name?
Wait. So both of them going up?
They're both
Metabolic.
going up. They're equal.
Would it be
Metabolic.
metabolic?
Metabolic alkalosis, yes. All right. Now this one, the arrow's going down here. We got two down arrows. So what is this?
It's gonna be acidosis.
Yeah.
And would it be respiratory?
No, respiratory is opposite. These arrows are both going the same way. So what is that?
Metabolic? No.
Metabolic acidosis.
Okay. So going the same way as metabolic. Got you. All right.
Yes.
Let's do
So
it now.
just remember Rome. Rome is right here. Respiratory opposite, metabolic equal.
Okay. It
Okay.
kind of makes sense when you use the arrows. It makes more sense.
It do.
Yeah, that's why I want you to take your scratch paper and write pH, PaCO2, and bicarb. And make sure you're picking the right values because the exam question might be shady and have like the PaO2 and the O2 sat in it. Okay, so make sure you're picking out the right values.
Okay.
All right. Is anybody able to get to that escape room I made about EKG, about ABGs and electrolytes?
I've seen it. I didn't get into it yet.
Oh,
I started it. I didn't finish it.
yeah, you really like read those rationales. Let's see if I can find another one. Let me do osteoarthritis, okay, and then maybe we can come back to that. Have you guys gone to like ABG Ninja? Have you heard of that website?
No.
I have.
Okay. I don't want you to get, well, we can try it, but I don't want you to get frustrated because that goes through like compensation and you don't need to know that right now. Okay? You just need to know how to identify a regular run of the mill ABG for this exam, okay? So we can try some after that. Let me just do this real quick. So osteoarthritis is different than rheumatoid arthritis. This is not an inflammatory condition. It is due to like aging, wear and tear on the joints. In fact, you know, when it's cold outside, my knee hurts. My knee hurts because like I run and walk and so I just, you know, I take NSAIDs to help with that, but it's not symmetrical or systemic. Okay, so it's going to be in one or two joints usually, either like the hip or the knee. Here's somebody with rheumatoid arthritis, so they have the swan neck, and here's somebody with osteoarthritis. So they have like deformed hands, but with osteoarthritis, it's not as debilitating as the swan neck. Anyways, with osteoarthritis, the pain improves at rest. Yes.
So does it start off with osteo arthritis and then go to rheumatoid?
No. Okay, that's a good question. No, it's two different things. So rheumatoid arthritis is an autoimmune condition, right? It's a disease of the disorder of the connective tissue. So it's an inflammatory condition, right? And you know, who knows why somebody got it. It could run in their family, you know, they just have the risk factors for it. Osteoarthritis is more in older adults, like as you age, the wear and tear on your body. Okay, and it's not inflammatory. It's just arthritis in a couple of joints in your body. Okay, whereas with rheumatoid arthritis, it's all over your body. Okay, so it's systemic. All right, so with
Okay.
osteoarthritis, the risk factors are age, obesity, repetitive joint injuries. Um, the nursing care, people with osteoarthritis, you know, depending as it progresses, okay, they can develop limping. So you're going to check their gait. You have to tell them to bend at the knees and not the waist when they want to pick something up. Okay, that's just good practice for everybody. We want to encourage assistive devices always, encourage rest, heat therapy, definitely. Moist heat is good, and maintain a healthy weight. Okay, they're going to be taking probably NSAIDs, like I told you I was. Um, and so here's like the difference. So with osteoarthritis, it's asymmetrical. It happens on one side of the body. With rheumatoid arthritis, it's symmetrical. It happens on both sides of the body. Oh, this is a picture of Raynaud's phenomenon that I was talking about, because people with rheumatoid arthritis may have Raynaud's. So here's the fingers turning white, then blue, then red. Okay. Now, both osteoarthritis and rheumatoid arthritis can develop, can have total knee replacement, total hip replacement, so total joint replacements, and that's called arthroplasty, okay? So the pre-op, post-op care, we talked about that at the beginning of the semester. Similar, it's the same thing, okay? I just want to interject a few things. If somebody's going to have a total joint replacement, that's a pretty bloody surgery. So they might want to donate some of their own blood before the procedure. They're going to be screened head to toe for infections. When I worked in a total joint center of excellence, even like a urinary tract infection, it gets delayed. Surgery gets delayed, or if I had somebody that was complaining about tooth pain. Surgery was delayed. The surgeon will not operate if there's any infection in their body anywhere. Anytime somebody has an orthopedic problem like fracture, surgery, they're in traction, you just put them in traction. You're going to do neurovascular checks every hour times 24 hours. Okay, then you can go to Q4. But like after surgery, it's going to be every hour times 24 hours. And then this is a CPM machine. Somebody with the total knee joint may get this. And what this does is it keeps the leg in continuous passive motion. So it's going to move the leg so it extends and then flexes back. Now, what you have to worry about is this is usually maybe put on a bed. It needs a nice flat surface. No, you got to make sure like the blankets don't get tangled up in these wires here, and that you're going to so they have like these buttons, and the provider will like give you the orders of what they want it to be set at, and you have to set that. So anybody with a total knee replacement cannot do deep knee bends for the rest of their life. And anybody that's had hip surgery, total hip, so they're going to have this abductor pillow. So because you do not want the leg on the side the hip, the same side the hip was done, to adduct, meaning go in, okay? You also don't want the toes to internally rotate, which means like if this toe was going in that way, it would be internally rotating. Now this is good. This toe is externally rotating just a little bit, okay? So that's good. Now, as you can imagine, you have this abductor pillow, and you've got these straps around it. So they're going to be at risk for alteration in the peripheral circulation. Again, when they first get it on, you're going to be checking the neurovascular checks frequently, right? Make sure the straps aren't too tight. They'll be on total hip precautions, which means they have to lay supine with the head of the bed elevated a little bit. The affected leg has to be in a neutral position, and they have to have this pillow in place when they turn. Yes,
I'm sorry. I have two questions. So,
yes.
with their would that ever like I think it's called the abductor pillow. I'm trying to zoom it in, but will it ever like will they be able to ever like relax from it, or they have to keep
Oh
that on
yeah,
as
get
a
it
hip?
tape, like not use it anymore. They can, yeah. So this is used like right after surgery when it's healing.
Right.
If you're
So
putting
how
them on the
long do
bed
they
pan,
have?
you keep it on. I'm
I'm
sorry,
sorry.
go ahead.
How long do they have it on after the surgery?
Usually till they go home. When they go home, they can use pillows, like a couple pillows between their legs, because they're going to have to if they lay on their side, or anytime they want to roll over, they have to have something between their legs. They can't adduct.
Okay, so
Okay,
if
like
they're
they
in the
can't even cross
supine,
their legs for 3 months.
gotcha. Okay,
Yeah.
so if they're in a supine position, what would the nurse like tell them to use? Like, would they be attached to like a
Oh,
Curvic or like
yes, they could be attached to a pre-work. That's a very good idea, actually. But also, with orthopedic surgeries, have you seen an orthopedic bed?
orthopedic
Like
bed?
they have
Yes,
like
I've seen.
the metal rod. Get a trapeze so that they can help scooch themselves a little bit,
Gotcha.
right?
Okay.
That helps keep them independent. And you also want to check their skin integrity really well,
Okay.
right? All
Okay.
right.
Thank you.
So they need to avoid this mnemonic I learned when I was in nursing school called flare. So flexion of the hip. The hip cannot bend greater greater than a 90-degree angle. Like you don't want it to go. And if I'm in class tomorrow night, let me show you what I mean by that. Okay, so somebody asked me to sit down, to show you how they would have to sit down. And then adduction, so you don't want adduction, which is the A, and IR stands for internal rotation. So that means these toes pointing in. Okay, that's what that means. So this is important, the patient teaching. You can tell them it's okay to lie on the operative side. They can do that. Okay, if they're going to be on their side, have to have pillows between their legs. They cannot cross their legs for 3 months. Okay, and it's okay to bend at their hip, but not beyond a right 24-degree angle. Okay, avoid sitting in low chairs, and that's for like anybody that has mobility issues. You want to make sure they have strong, like the arms on the chair are high enough and strong enough so that they can push themselves up. Um, they need elevated seating. They're going to have to use handicapped toilets, and they need, before they can go home, they have to have like an adapter for their toilet. Okay, because they shouldn't go beyond that 90-degree angle of their hip. Um, they have to keep up their daily exercise, and they're going to be in PT when they first have it. So when I worked in the PACU, we were a center of excellence, and we did a lot of these surgeries. They were out of bed the same day they had the surgery and up walking with PT. So that was awesome. All right. So does anybody have any questions for me?
Just to trace back on the HIV, because it wasn't on that list of interventions, but should we be still teaching the client to clean up blood spills with bleach or?
Yes, yes.
Okay,
Yeah, you would still do that 1 to 10 solution.
cool
Um,
beans.
Yeah.
the what was it? The SoundCloud that you sent us?
The what I
Um,
sent you?
it was like a SoundCloud
Yeah,
that
those,
popped
okay,
up.
so those are audio lectures. And what I do when I make a lecture, I extract it out of that lecture. So it's the same lecture as in my YouTube videos, but you can listen in the car, you can listen when you're walking your dog. So I just extract that lecture. Does that make sense?
Yes, ma'am. Thank you.
You're welcome. It's just another way for you to stay connected, because I know everybody is busy, so I have various methods that you can study.
Thank you so much.
You're welcome. I want to see if I can find ABGs. Can you guys still see me? Still see my screen?
Yes. Mm-hmm.
Okay, hang on for a
Yes.
second. I had this worksheet yesterday that I think would be perfect for this. I want to see if I can find it.
Should we expect the ABGs on the exam tomorrow, right?
No, the exam's next week.
Next week. Okay, so should we expect, like, we're gonna expect all of those on there, right?
Yeah, you're going to have to do, you have like 4 questions. You have to do four, you get a scenario and the ABG.
Uh-huh.
Yeah, so you will have to know how to do that.
Okay, and it's
But
still gonna
like,
be 5 math questions.
say it again.
It's still gonna be 5 math questions on there.
Yes, you have throughout nursing school, you'll have 5 math questions on every exam.
Okay.
Yeah. All right, let me see if I can find this. All right, so let me see if I can upload this sheet of paper.
While you're clicking, can I ask a question?
Yes, of course.
Okay, cool beans. So it was just something that popped up in my head, and I'm probably off track. But when we was talking about the calcium deficiency,
Uh-huh.
those symptoms how do those symptoms differ from tardive dyskinesia, or is that tardive dyskinesia?
Tardive dyskinesia? Is that what
Yeah,
you're talking about?
yeah, because isn't that like the twitching of the face and stuff? But that comes from
Yeah, that looks a lot different.
okay. That's why I
Yeah.
wanted to know. I wanted to know like what's the difference
Are you
between.
studying that in pharmacology?
I think it's coming up. That's what
Okay.
made me ask about it. I think we spoke on it like the week before last a little bit, but I don't think that we've talked about it like in depth in class yet.
Uh-huh.
But I just wanted to make sure that like I could recognize like all right, this person is these are symptoms of low calcium versus this is tardive dyskinesia. Because I know that
Yeah.
tardive dyskinesia comes with those, like your SSRIs and all that stuff.
Yeah, it's also like it looks like more like mouth movement.
Okay.
All right, I'm gonna see if this will work. All right, you guys see this?
Yes, ma'am.
All right. So let me see. Can I draw on this? Oh my God, if this works, I'm gonna be so okay. Let me see if this is gonna work. What am I gonna do with this arrow? Is it going up or down?
Up, down.
Up.
Oh, what?
7.68 is up, right?
Mm-hmm.
Yeah.
What is the PaCO2 of 38? Up or down or neutral?
Is it neutral?
Neutral.
Yep, it's normal, right? What about this bicarb? Is it up, down, or neutral?
Down.
Is it low?
It's neutral.
No, no. So the normal bicarb is 22 to 26.
So it's high.
Yeah.
So both of the arrows are going up, so that's
Okay, so let's do the last name first. What's the last name?
Doses.
No.
Alkalosis.
Acadose.
Metabolic alkalosis.
So if the pH is over 7.5, it's alkalosis.
Up is low. Up is low. Okay.
Okay.
That's the part I keep
So
getting confused on.
okay, so if the pH is greater than 7.45, it's alkalosis. If it's less than 0.35, it's acidosis.
Doses. Okay.
Okay? All right. So, and what about, so they're going the same way. So the last name is what? Alkalosis. And they're going the same way. So what is this?
Metabolic.
Metabolic?
Metabolic. Very good.
Okay. All right. All right.
Okay. So 7.48 is, which way am I putting the arrow?
Up.
Up.
is it up?
Okay. Okay. PaCO2 of 28. Is the arrow going up or down?
Down.
Down. Okay. Bicarb of 23.
Neutral.
True.
Neutral. Okay. So what's the last name?
Up. Low.
Alkalosis.
Alkalosis.
Right. And the arrows are opposite. So what's the first name?
Respiratory.
Respiratory. Very good.
Got it.
All right. So this next one is my arrow up or down for the pH?
Down.
Okay. Okay. Is my arrow up or down for the CO2?
We neutral.
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 Neutral. Okay. All right. What about the bicarb? Up or down?
Down.
Down.
Down. Okay. What's my last name?
Down.
Acidosis.
Acidosis.
Acidosis. And these are going the same way. What's my first name?
Metabolic.
Metabolic.
Metabolic acidosis. Very good.
Okay.
Okay. All right. What is this one? Up or down? pH?
Up.
Is it up?
Up. Okay. What about the PaCO2?
Neutral.
Neutral.
Neutral. Okay. What about the bicarb?
It's up.
Up. Okay. What's my last name?
Losis.
Acidosis.
Alkalosis.
Alkalosis. So what kind of alkalosis is it?
Metabolic
Metabolic
acidosis.
alkalosis.
Metabolic. Very good. All right. You guys are pros now. What's this one? pH?
That's
Down.
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 Down. Okay.
This
And
is
what's
up.
the PaCO2?
Up.
Up.
Up. Okay. What about the bicarb?
We neutral.
Okay. So what's my last name?
Acidosis.
Acidosis.
Acidosis. And these are opposite. So it's what kind of acidosis?
Respiratory.
Respiratory.
Very good. All right. 742.
742.
That's up.
Neutral.
Neutral.
That's
Okay.
neutral.
All right. The PaCO2.
Neutral.
Neutral.
Okay. And the bicarb.
Oh,
That's
neutral.
neutral too, right?
Neutral.
Okay. We're going to continue to monitor. This is homeostasis. All right.
Homeostasis. Okay.
Okay, so pH of 7.2.
Wait.
Neutral?
Wait.
No, low.
No,
No, that's
What's the
acidosis.
that's
what's the
acidosis. You're right.
second, the one
Low.
before that?
Okay, the PaCO2 of 39. Neutral,
Neutral.
low,
Neutral?
neutral.
That should be
Okay. And what about this bicarb?
Low.
Low. Okay, so what's this ABG?
Down.
Metabolic
Acidosis.
high.
acidosis.
Metabolic.
Acidosis.
Metabolic acidosis. Very
Keep
good.
going. Can you
All
go
right,
back over
let's do
that
this
one?
last one.
Can you
Okay,
Hold on,
ready?
I think Lakia got a question.
Oh, yeah, go ahead, Lakia.
I'm sorry, I don't know if I'm talking to you, but I don't understand this one. So if it's all of them are neutral, you said it's homeostasis, so keep
It just
monitoring.
means it's another way to say normal ABG.
Okay,
Okay.
thank
Yeah,
you.
that's all that means.
Okay.
Yeah. All right, so 7.58, what's that?
Hi.
High.
Alkalosis.
Yep, very good. And this is the PaCO2 is what?
Neutral.
Neutral,
Neutral.
Neutral.
Neutral. And what about the bicarb?
up,
So it's metabolic.
Metabolic
metabolic,
alkalosis. Very
Alkalosis.
good.
acidosis.
You see, it just takes a little practice.
Thank you.
Yeah, so you got it. If you just practice over and over, you just got to remember to draw the arrows. Now, when we do activities tomorrow, I'll go in a little more depth, like what it means, right? If the CO2 is low, right, the patient's breathing too fast, what you're going to do about it, right? Definitely do that escape room I made. Read all the rationales and do it without your notes, okay? Because it's like a pre-gaming, right? So you should study, like do a good study session, and then what you should do is go and take that. Remember, it's not a real test or a quiz, so you just use it as a study tool and just go and read the rationales and incorporate what you didn't understand into your current notes, okay? Then wait a few days and try to do it again and see if you do better. Okay? Um,
Okay.
that's a good way to approach it. Um, so the lectures are really short, okay? Like 10 minutes or less. That's so you can study daily because students are like, oh, I need like 3 hours to study. You don't. You can study just 20 minutes a day in med surge, 20 minutes a day in pharm, 20 minutes. How many are taking an A&P?
I
Study,
am.
yeah, study 20 minutes in A&P and just do like little bits throughout the day. If you did that sequence like 3 times a day, you'd be like at an hour for each subject, right? So there's a lot of research that if you mix up what you're studying, in other words, don't study med surge for a whole hour. If you study med surge for just 20 minutes and then pharm for 20 minutes and then A&P for 20 minutes, it causes your brain to learn more. It helps you learn better. It's called interleaving. So it's a good strategy to use. Are any of you like in study groups?
On and off.
Nobody's in. No, you guys aren't in study groups. You don't like each other.
I think so. Like last semester, we did a lot of study groups, but then it was just like the groups were too big. So then it would
Yeah.
it was just too much. So I mean, like this semester I've kind of condensed down and picked like, 2 people that I study with really good, and that's been working because
Yeah.
it's
So
like
let
we
me tell
all
you,
have our
like,
weak points.
that's a really good plan to have a smaller group. So the perfect study group is like 5 people, right? One has to be the leader. And let me just tell you, you don't even have to like the people, okay? Because the study group is about studying. It's not about social hour, right? What you do as the leader is you assign each person in the group something they're going to teach back to the group. I don't know if you know this, but teach backs that we make you do in the class, students hate them. That's the highest form of learning because if you have to break something down to teach somebody, you're going to have to really know it well, right? So you meet for your study session, and each person in the group goes around and teaches the other members of the study group about whatever it is you're talking about, right? And then what can happen is everybody in that study group will add, well, I remember this. I remember the instructor said this. So you add kind of, then they contribute to it. And then that way, you know, people are always going to hear something that you maybe missed, right? So that's like a good strategy to have a study group that works for you, right? Because this program is no joke. It's a hard program.
We're in a triangle of death right now. Med surg,
You're,
pharmacology.
is that the triangle of death?
Yeah, triangle of death.
Yeah, that's what they call it in the ADM program. They have like patho, med surg, and farm. Yeah, that's it. All right, so tomorrow in class, did you guys get a chance to listen to the lecture for
Um,
tomorrow?
a little bit of it.
I'm sorry, I can't hear you.
Just a little bit, not so much. We got an
Okay.
exam for pharmacology Thursday too, so
Do you have
we'll
an
be
exam
speaking.
in farm on Thursday?
Yes.
Mhm.
Yes.
Oh,
Yeah.
okay.
So
Your
we kind
second
of just been
exam?
focusing on that.
Okay, all right. Well, do you have time to go over it?
Yes.
We can
What
make time.
pharmacology?
No, like now, do you want to go over it? Like so you can come, because tomorrow when you come to class, I wrote like this monster case study that we're going to do together. And it would help if you know, like, not know the information, really well, but were exposed to it, put it that way.
You're coming to the morning class?
Oh, you're in the morning class. Okay, no, I'm not coming to the morning class. Sorry.
We
Yeah,
can still
we're
go
in
over
there
it.
with Mr. Wyko, but yeah, I don't mind.
Okay, I'm trying to, all right, let me see. How do I do this again? We used to use these like when we were out for, this platform when we were out for COVID, and I haven't done it in so long that, okay, here we go.
This is still being recorded, right?
Yes,
Recorded, right?
yes.
Okay, because I wanted to
Can you
get
see
a
my
picture of
screen, or
that.
is that white thing still there?
No, we can see
Yeah,
the
I can
screen.
see it.
Okay, all right. So we're going to talk about chronic illnesses, okay? So this is like really just a recap of your fundamentals, okay? Um, we're going to talk about chronic illnesses, rehab. Having a chronic disease is like a full-time job, right? They have appointments to go to, they got to see different doctors. People can like lose their sense of power, right? If they get a chronic illness and now they're dependent on people. So one of the goals is always going to be to foster independence when you're taking care of people with chronic illnesses in like skilled facilities or rehab facilities. All right. So the chief goal, yes, is you want to restore their function to the highest level possible, but we can't promise that we're going to restore them to what they were before, right? You understand that? So we have to, like, for example, if somebody had a stroke and they have contractures, we have to do passive range of motion. Passive range of motion is going to help prevent contractures. It's not for strength, it's to prevent them from having contractions, okay? So it helps with joint mobility, the ROM. You do it 3 to 4 times a day. And it doesn't increase muscle strength or muscle girth. Um, and then to prevent osteoporosis, you want people weight bearing, um, walking frequently. And then with cardiovascular complications of immobility, it's the DVT. I think you know all this. You had it in funds. We talked about some of this stuff at the beginning of the semester. All right, so you know how to prevent DVTs, the prophylaxis, the TEDs. If somebody has constipation, increase their fiber and fluids, increase their activity. We always do that first before we do stool softeners, and avoid constipating foods like milk and cheese, okay? Um, and neuro-wise, they could get disoriented. So what really helps is a room with a window okay? Reorient them frequently, and like if they're in a skilled place, having a calendar with big numbers on it, that can help as well. All right, and then respiratory, they're going to be at risk for pneumonia. So you want to move them around. So the signs and symptoms you're looking for is a fever, high heart rate. So tachycardia happens in response to stress in the body. So basically, like anything that somebody gets, they're going to have tachycardia pretty much most of the time, except when we get to neuro, it'll change. Crackles, so lung sounds, you're going to hear crackles. They'll have a cough, increased respiratory rate, and a positive sputum culture. All right. So I think you know the interventions for skin breakdown, turn Q2, use a trapeze like I talked about earlier. Also eating protein and vitamin C if they do get broken down, so that they can heal. Restraints. Okay, we got to go over that again. So the restraints are only used if the family can't stay with the resident. If we've already done everything we've tried, right? We moved them closer to the nurse's station. We gave them towels to fold, tried to distract them. It's not used because you're short-staffed. You have to check on patients frequently. You need an order, okay? That's very important. And you're going to use the least restrictive device first, okay? Use the least restrictive device. Skin checks are done every 2 hours. And then you're supposed to check on them every 30 minutes if somebody is in a restraint. This is in like a rehab or skilled nursing facilities. Okay.
And these
So
restraints are doctor's orders, right?
always you have to have doctor's orders for a restraint. It's like a big deal,
Yeah.
right? Big deal. So when can you apply it? If you have an order and the family is unable to sit. And I talked about least restrictive. Now, don't turn your alarms off like your bed alarms, because you want to know if the patient's getting out of bed. All right. To help your patients if they're confused or get disoriented, consistency with the schedule is paramount. So they have to have, it's got to be like Groundhog Day. They get up, they eat breakfast, they do the same things. Okay. Limit the number of choices for them. Okay. Just give them two things to pick from if they're doing activities. Time schedule posted in large print. I talked about that earlier. You want to avoid putting them in unfamiliar situations. You want to limit visitors to 2 at a time because it's going to be too overwhelming. Okay. Use a nightlight so they don't fall. You want to encourage people that are living in a skilled facility to pursue a hobby or refrain from doing, you need to refrain from doing tasks for the resident that they can do themselves, which is hard for people that don't have patients. Like sometimes I found it hard when I had a patient that had a stroke or something and had to be patient and give step-by-step instructions when I could have just done it myself and been on my way, for them. But it's really important for them to maintain their independence. Use adaptive devices because that helps them maintain function. They should you should put on TV shows like cooking shows, travel shows, something that's going to help their cognitive function. Okay. Scientific shows. They should do crossword puzzles, card games. Like I like doing math because math helps engage my mind. I know that's weird, but I like doing ABGs too because that gets me thinking. Okay. And the goal is always to promote functional and social well-being, and we start rehab on admission to the hospital. Okay. And the good way to encourage independence is let them to do those ADLs by themselves, give them step-by-step directions, and encourage adaptive devices. If you have somebody that is having a problem, like say it's a stroke patient or and they're hemiplegic and they're having trouble dressing themselves, have a peer come in and that's had the same problem who can now dress themselves um, to show them that, you know, it is possible that they can, you know, not get better, but be more independent. Okay. Okay. So we're going to talk about musculoskeletal now. So if you have like a strain, a sprain, you're going to want to use the RICE method. So this is used for first aid, okay? R stands for rest, I stands for ice and immobilization, C stands for compression, and E for elevation, okay? You're going to use cold therapy for 72 hours, then you can use heat. Okay, so you you never want a patient to ice continuously. So you want them to ice every 2 hours, but only for 10 to 20 minutes at a time. If you come across somebody that has a compound fracture, now a compound fracture is an open fracture. So the bone is sticking through the skin. Okay, so the wound, there's a wound that's open and they have a fracture. Okay, so what you're going to do is don't try to fix it. You're going to splint the leg as it is. So splint as it lies is what they say. Okay. You're going to have to do the 6 Ps, right? So make sure you remember the 6 Ps and how to assess them. Okay. So you can go over that. And then if somebody has a cast, okay. So casts are used for closed fractures. And when you put on a cast, there's two different types of casts. It could be a fiberglass cast. That dries pretty quickly. But the Paris, plaster of Paris casts take a long time to dry. So you're going to ask what kind of cast the person has. Okay. As the cast dries, it generates heat. So you're going to have to ask the patient about it because they can get a burn from that. Okay. So you need to know that. You want to elevate the extremity to minimize swelling for 24 to 48 hours. It also helps prevent compartment syndrome. You want to hold a wet cast with the palm of your hands and don't use your fingers because you're going to put dents in the cast, which could then, you know, poke into their skin. A burning pain could mean the start of a pressure ulcer, so you would let the provider know and they cut a window in the cast if they need to. You can try repositioning. Tell them not to put sharp objects under the cast. They can use a hair dryer on cool if they're itchy, or take a 60 ml syringe and put air in it and just like blow it in there where they're itchy. And then plastic bag over the cast if they can shower, and then use a trapeze bar. The other thing with casts is when you're checking their skin, see you need to see if you can put one finger in between the cast and their skin. Now, don't get confused because with restraints it's 2 fingers, but with a cast it's 1 finger. Okay. All right. So ice bags against the cast, not on top of the cast. A dry cast is white, shiny. A wet cast is gray and dull. All right. Keep in mind that prolonged immobility can lead to disability from frozen joints. So you always want people moving and doing passive range of motion if they're flaccid or they have flaccid muscles. Okay. How often should you do neurovascular checks on a new cast? Every 1 hour times 24 hours. Okay. Management of pain, you elevate. Okay. So if let's say you medicate your patient, but they're still complaining of pain and it's like out of proportion to what you think it should be, okay, they could have compartment syndrome. So if that pain is not relieved, you need to call the provider, okay, because they need to go to the OR ASAP. All right. I already talked about range of motion. Skeletal traction. Okay. So skeletal traction means this traction, they put it in with pins into a bone, right? And then it's hooked up to a weight system with pulleys that pulls this bone down. Now they use it preoperatively now. They don't really use it that much anymore. They use more skin traction before surgery, like if somebody fell and broke their hip. So if you see this, the big deal though about this or external fixators is that you have to check this site for infection and you're going to do care on it like every shift, okay? pink here means you're taking a Q-tip and you're going to wipe around it, one wipe, and you use one Q-tip per pin, okay? Because they could get osteomyelitis, okay? So skin traction is like the traction is put on, they use like bandage, and it's to reduce Buck's traction is a type of skin traction. That's what I think you'll be tested on if you get a test, a question on NCLEX. It's to reduce muscle spasms. Oh, this isn't coming up, but you want to keep the patient in the center of the bed if they have traction, keep the body parts traction in the same line with the trunk. So you're going to check for the 6 Ps. Make sure your weights are hanging freely. Like, I don't know if you can see this picture, but these weights are not on a table or anything. They're hanging freely, okay? And this foot is not up against the footboard. You don't want that either, okay? So don't adjust the weights. It's okay to put your patient up in bed, and they can do it with the trapeze too. Don't let the feet touch the footboard. Observe all bony prominences. You're going to check their skin Q2. Examine, don't forget the skin under the boot, the traction splint, okay? Make sure you're checking that skin, and make sure the ropes hang freely and there's no knots in them, okay? All right, so here's traction. Check their extremity for infection, okay? If somebody has skeletal traction, they're at high risk for osteomyelitis. They'll get like a really high fever and they'll be complaining of really bad pain at the pin site, and it'll be tender, red, swollen, all those things.
And
All right,
osteomyelitis, that's infection of the bone, correct?
it is.
Okay.
It is. And okay, one of the reasons you don't, I mean, you never want to give a patient an infection, but osteomyelitis takes a long time to treat. They're going to have some kind of vascular access device, okay? Um, so it's a infection of the bone. So they're going to have sudden onset of severe intense pain. They'll have tenderness at the site, high fever, so basically an infection. Compartment syndrome is there. I can't expand this. In the video, I expand this. But anyways, if they have pain that's unrelieved by narcotics, okay, you need to call the provider, okay, because they're going to need surgery, right, for that. And the best, before they get compartment syndrome, the best thing to do is elevate the limb. Once you think they have compartment syndrome, take it off of elevation, okay? This is
Does any
osteoarthritis.
does any of this all right, so say like how you said take the foot or whatever the part of the body is that's affected, right? You drop it. Will any of this like for the feet, is it possible like doing any of this would make us increase their chances of like developing drop foot or anything like that because they can't really move it?
Well, okay, so compartment syndrome is a medical emergency. So I'm worried about saving the limb. You might think this is a long time, but when there is ischemia to a limb, you have 6 hours to get that fixed, or they're going to lose that limb, right? So when that happens, you got to call the surgeon. They got to mobilize the team. Like, it's probably going to be in the middle of the night, right? They got to mobilize the OR team to come in. So it's going to take a long time. You're not really worried about foot drop at that time because that's more of a chronic condition.
A chronic condition. Okay.
Yeah, yeah. So we already talked about osteoarthritis, and we talked about one thing I didn't mention. We talked about arthroplasty, total hip. So total hip replacement is the surgery with the highest risk of DVT. They have to be on prophylaxis, okay? And I already talked about the abductor pillow.
Prophylaxis, blood thinners? No?
Uh-huh.
Yeah. Okay.
Yes, definitely, definitely. Talked about teaching. Risk factors for osteoporosis. We'll talk about that tomorrow. And I'm going to do, I will do amputation when we do the vascular lectures. Okay? So how are you guys feeling so far?
I feel much better now that we went over the ABG like now I get it. I get it for real this time. And I got a question for
Uh-huh.
for a cardiac infraction for a heart attack, right? Say for instance, if we're in the emergency, we would push epi before we do aspirin, correct? And
Okay.
in what scenario will we use aspirin before epi? I guess is my real question.
Okay. Epinephrine, when we're talking about cardiac arrest, is for dead people.
Okay, right. You push that through the IV if they
Right.
don't have a
So
heartbeat.
if they're dead, they're not going to be able to take aspirin.
Right.
But if somebody comes in with an MI, you want to ask if they've already taken the aspirin in the field, but you would get that in because you're not going to give epinephrine unless they're in cardiac arrest.
Cardiac arrest. Okay.
Yeah. So are you learning about monotherapy?
Yeah, I started learning a little bit. Like I move ahead a little bit so that I don't